It's really fascinating, isn't it? How modern medicine lets us, peer inside the body without even making an incision sometimes.
Absolutely. It's changed so much.
And especially in vascular surgery. I mean, we're using these catheter-based techniques more and more.
Very
Delicate stuff.
Very delicate.
So having a detailed, real-time inside view during an operation, that's not just nice to have anymore. It feels essential.
Oh, definitely. You might be surprised how much these minimally invasive methods have taken off, and that's really pushing the need for better imaging right there in the OR.
The ability to actually see what's going on inside a blood vessel while you're working, that's got to be transformative.
It is, completely. It brings a whole new level of precision, and,
Right.
well, it can be crucial for preventing complications.
Which brings us right to our topic for this deep dive. Intravascular ultrasound, IVUS.
IVUS, yes.
Now, if you're not familiar, basically, IVUS is like a tiny ultrasound machine on the tip of a catheter.
A miniature one, yeah.
Doctors thread it into a blood vessel, usually over a guide wire, and it uses sound waves to create images from the inside. Think of it like having a tiny little camera, well, not a camera, a seeing eye right there at the working end of the instruments.
That's a great way to put it, a seeing eye inside the vessel.
And for this deep dive, we've really gone deep into Rutherford's vascular surgery and endovascular therapy, the 10th edition, specifically the chapter all about IVUS.
This is a fantastic resource, really comprehensive, covers everything from the basic science to all the ways it's used clinically.
So our goal today, for you listening, is to really break down this technology.
Demystify it a bit.
Yeah. We want you to get a clear picture of how IVUS actually works, where it's making the biggest difference, what the pros and cons
And
are.
its limitations, yeah.
And maybe even peek at what's coming next. Basically, give you a solid understanding of this honestly compelling tech that's helping surgeons get better results and cut down risks for patients.
Sounds good.
Okay, let's unpack it. How exactly does IVUS make these pictures from inside a vessel?
Okay, so at its core, it works by sending out sound waves. But not just in one direction, it sends them out 360 degrees all around from the catheter tip.
All around. Got it.
And when those sound waves hit the different tissues in the vessel wall, they bounce back. They echo. The catheter picks up those returning echoes. Then the system processes those echoes and builds a cross-sectional image. So you're looking at a slice across the vessel perpendicular to its length.
Interesting. And I think I read there are a couple of main ways it actually sends out those 360-degree waves.
That's right. Two main technologies. First, there's the mechanical system. You mostly see that from Boston Scientific. It uses a single ultrasound transducer that, well, it physically rotates, spins really fast at the tip of the catheter.
The bibs, wow.
Yeah, on a flexible drive shaft. That spinning action covers the full circle. Then you have the electronic system. Volcano Corporation, now Philips, pioneered that.
Okay, different approach.
Totally different. Instead of one spinning part, it has an array, like a ring of many tiny transducer elements, maybe 64 of them around the tip.
Wow, 64.
Yeah, and they're fired off in sequence one after the other very rapidly to build up that circular image. So, mechanical might be simpler in some ways, electronic might be faster, trade-offs.
Right, trade-offs. But both get you that 360 view. And you mentioned a guide wire earlier. How does that fit in?
Yes. Crucial point. The IVUS catheter itself, whether it's mechanical or electronic, gets advanced into the vessel's lumen, the open channel, over a standard guide wire.
Okay.
That wire is key for navigating, the twists and turns of the vascular system and getting the IVUS tip exactly where you need it to be.
Makes sense. So sound waves go out, bounce back, catheter picks them up. Then what? Where does the image appear?
So all that echo information travels back down the catheter to a separate console, a workstation, basically.
Right.
That's where the magic happens. The raw data gets processed, turned into the images you see on the screen. And the detail is pretty impressive. You can measure things in real time, vessel diameter, circumference, the cross-sectional area.
Area too. Right?
Yeah, and you can freeze frames, capture still images, or record video loops as you pull the catheter back through the vessel. There's actually a figure in the book, 32.1, showing how you can measure diameter and area and even quantify thrombus blood clot by comparing the open channel area to the total vessel area.
That's amazing. Having those exact measurements right during the procedure must be invaluable.
It really is.
Now, it sounds like picking the right IVUS setup isn't just grab and go. especially the catheters and frequencies.
Oh, absolutely not. Choosing the right catheter and the right ultrasound frequency is critical. It's all about getting the best possible image for the specific situation.
How so?
Well, higher frequencies give you better image resolution, finer details. You can see the layers of the vessel wall more clearly, subtle plaque features.
Okay, high frequency, high detail. Sounds good.
It is, but there's a trade-off. Higher frequency sound waves don't penetrate as deep into the tissue.
Okay. Less penetration.
Exactly. So for smaller vessels, like the coronary arteries and the heart, where you really need to see those fine details of the plaque, a high frequency, maybe 45 millihertz, is often the way to go.
Right, like a sharp flashlight beam that doesn't reach quite as far.
That's a perfect analogy. So what about bigger vessels then?
What about bigger vessels? What do you use there?
For larger peripheral arteries, or maybe vessels with lots of branches, you often go for a mid-range frequency, something like 20 megahertz. It's a balance, you know? Decent resolution, decent penetration.
A good compromise.
Sort of. And then for the really big ones, the aorta, the vena cava, the main iliac arteries, you'd use lower frequencies, maybe around 10 millihertz.
And why lower there?
You sacrifice some of the superfine detail, but you get that deeper penetration needed to see the entire circumference of those large vessels. The book actually has a table, 32.1, listing different catheters, their frequencies, sizes, lengths, imaging diameters. It really shows how tailored the tech is.
Definitely not one size fits all.
Right.
You're picking the tool for the job, for the specific vessel. Okay, so we've got the image on the screen. How do doctors actually read it? It looks like just shades of gray, right?
It does take a trained eye, you're right. It's all about interpreting that grayscale. Like other ultrasound, the image is built from bright white to, well, deep black. And the brightness or darkness of any spot depends on how well the sound waves penetrate and the strength, the amplitude of the signal bouncing back. We call that echogenicity, how bright. How much echo, or echolucency, how dark, how little echo.
Okay, echogenicity, echolucency.
Yeah. There's a figure, 32.2, that shows the artery wall layers nicely. The inner layer, the intima, and the outer one, the adventitia, they usually look brighter, more echogenic. The middle layer, the media, is typically darker, more echolucent, and the blood flowing in the middle. That looks very dark, almost black.
And can you tell different types of plaque apart just by looking at the grayscale?
Often, yes. An experienced user can get a good sense. For example, really calcified plaque. Super bright, very echogenic, and it often casts a shadow behind it because the calcium blocks the sound waves.
A shadow, okay.
Yeah, posterior shadowing. Fibrotic plaque, more like scar tissue, that's also bright, but maybe a bit less than calcium, and usually no shadow. Soft, fatty, lipid-filled plaque, that tends to be echolucent, so it looks darker.
Interesting.
And there's software, too, specialized software that can help analyze these characteristics further.
Software aids, right?
Yeah.
Now, these are cross-sections, slices across the vessel. What about seeing the length of it, the whole picture?
Right, good question. That's where volumetric 3D IVUS comes in. Those 2D slices are great, but getting a full sense of the artery's shape, its morphology, and how the plaque is distributed, that's harder with just slices.
Yeah, I could see that.
Traditionally, you could do a pull the catheter back at a set speed, and the machine would sort of stack the 2D images to make a longitudinal view. But the problem was, the catheter tip isn't always perfectly centered in the vessel, right? It can wobble or sit off to one side.
Especially in bendy arteries, I bet.
Exactly. So those simple reconstructions could sometimes distort measurements, like diameter and length. It's like trying to reconstruct a whole banana from slightly off-center slices. You might get a weird shape.
Huh. Good analogy. That makes sense. Potential for distortion.
Precisely.
Yeah.
But the tech's moved on. There are much more sophisticated 3D reconstruction algorithms now. One method the chapter mentions actually registers 2 separate pullbacks of the same vessel segment simultaneously.
2 pullbacks. How does that help?
It helps correct for that off-center positioning, gives you a much more accurate 3D picture of the vessel and the atheroma, the plaque buildup. It's an area that's still evolving, getting better.
Sounds like a big step up for visualization. Now, the chapter also mentions color flow IVUS. What's that add?
Color flow adds another layer. It shows you blood flow patterns within the vessel.
Flow patterns, like Doppler.
Not quite like Doppler. It doesn't measure velocity, the actual speed of the blood. What it does is specialized software looks at a rapid sequence of IVUS frames, maybe 30 per second, and it detects the movement of red blood cells. Normal flow might be colored red. Faster flow might show up as yellow.
So not speed, but movement.
Right. Its real value is showing the interface, the boundary between the vessel wall and the flowing blood. This helps get more precise volume measurements of the lumen, the channel, and it's really useful after treatment, like putting in a stent.
How so?
You can use color flow to check for good apposition, making sure the stent is fully expanded and snug against the wall with blood flowing nicely through it. The book has a figure and a video showing this. So it's moving beyond just seeing blockages to understanding the interaction between the wall and the bloodstream.
Okay, visualizing flow at the wall, not just the speed itself.
Got it.
Yeah, this next one sounds really interesting. Virtual histology IVUS. VHIVUS. Sounds like looking at the tissue itself.
That's basically the idea. VHIVUS goes even deeper. It doesn't just look at the strength, the amplitude of the returning echo. It also analyzes its frequency.
The frequency, why?
Because different types of tissue within the plaque actually reflect sound waves back at slightly different frequencies. The VH software analyzes these subtle frequency shifts.
And then what?
And then it creates a color-coded map of what the lesion is made of. Instead of just gray, you might see dark green for fibrous tissue, yellow-green for fibrofatty, white for calcium, and red for the necrotic lipid core, the really unstable stuff. There's a figure, 32.4, showing these color codes.
That is incredible. So you can tell what the plaque is made of right there inside the vessel.
Pretty much. And this isn't just theoretical. It's been validated against actual tissue samples, histopathology from plaques removed during surgery.
Really?
Well, the Capital study is a big one. They compared VH-IVUS images with tissue from carotid endarterectomy surgery to clean out the carotid artery and found it was highly accurate for diagnosing different plaque types, especially the risky ones like thin cap fibrothromas. Another study in 2013 also showed high sensitivity for various plaque types.
So this isn't just a cool picture, it's giving real clinical info about the plaque stability.
Exactly. Knowing the composition helps predict how it might behave. Will it be tough to push open with a balloon? Is it likely to break apart and embolize, send clots downstream when you treat it? That's hugely valuable information.
That seems like a massive advantage for planning treatment and anticipating risks.
It is. There is a limitation currently, though. VH-IVUS works best in smaller vessels right now because the display field isn't huge, less than 20 millimeters. But you can bet they're working on applying it to larger vessels in the future.
Okay, fascinating tech. But let's talk brass tacks. How effective is IVUS in the real world? And what about the cost? These systems must be expensive.
You're right, they're not cheap. The systems themselves, back in 2009 figures, were maybe $100,000 to $200,000. And each disposable catheter can be $600 to $1,000. So yeah, it adds cost to a procedure.
That's significant.
It is, but there's a growing pile of evidence suggesting the benefits often justify that cost, especially long-term.
How so?
Because using IVUS can lead to more effective treatment. That means fewer repeat procedures down the line, better patient outcomes, less morbidity and mortality, especially in complex cases. That ultimately saves healthcare costs.
Right.
There was a cost-effectiveness study specifically on using IVUS and coronary interventions, PCI, for high-risk patients.
Yeah.
And it found IVUS was cost-effective, mainly because it led to more precise stent placement and better long-term results, which cut down on later costs. So yes, upfront investment, but potential for long-term savings and better health.
Okay, so the value proposition is there, especially when you factor in preventing future problems.
Yeah.
Beyond cost, what are the big general advantages IVUS brings?
Well, a major one, backed by lots of research, is just getting more diagnostic information, a more accurate picture of the disease.
Right.
Then, intraoperatively, during the procedure, that real-time dynamic imaging is key. You can guide graft deployment precisely, see immediately how well the treatment worked.
Instant feedback.
Exactly. And the measurement capability is huge for sizing stent grafts correctly, making adjustments on the fly based on what you actually see inside.
You mentioned potential distortion earlier, though.
Yes, good point. You still need good technique. If the catheter isn't centered, especially in a bendy aorta, the measurements might be a bit off from the true centerline diameter, so user skill is still vital.
Technology is only as good as the user, right?
Yeah.
What about contrast dye? That's a problem for some patients.
That's a huge advantage of IVUS. No contrast needed.
Not at all.
Nope. So for patients with contrast allergies or kidney problems, IVUS can be used for preoperative imaging instead of, say, a CTA. And during the procedure, using IVUS instead of, or alongside, angiography dramatically cuts down the contrast dose and radiation exposure. Less radiation, too.
Significantly less. One study showed it cut fluoroscopy time roughly in half. Back in 2002, a study even concluded IVUS was reliable enough for EVR aneurysm repair without any extra angiography. So minimizing contrast and radiation, massive benefit, especially for fragile patients.
Makes sense. Okay, let's dive into some specific uses. Arterial interventions first. Peripheral arterial disease, PAD, has IVUS used there.
Okay, PAD. We know that if you leave more than, say, 60% narrowing after just ballooning an artery, the long-term results aren't great. And getting the size right for balloons and especially stents, that improves outcomes too.
So sizing is key.
Crucial. IVUS lets you measure the lumen diameter precisely, see how bad the stenosis really is. That helps pick the right size balloon, the right size stent. There was a Japanese study looking at leg arteries, femoropopliteal, found the 5-year success rate was way better, like 65% versus 35% when they used IVUS during the procedure.
Wow, big difference. Huge. And IVUS also lets you check the result right after you inflate the balloon or deploy the stent. Is it fully expanded? Is it sitting snugly against the wall well opposed?
Can't you see that on angiography?
Not always very well. Angiography just shows the shadow of the dye column. IVUS lets you see the actual metal stent struts because they reflect sound, and you can assess how well expanded and opposed they are. One study found a bunch of stents weren't fully expanded initially, but they saw it with IVUS and could fix it with a bigger balloon right then and there.
So fine-tuning the mechanics of the fix.
Exactly, optimizing it. Even for things like popliteal aneurysms behind the knee, IVUS helps map out the aneurysm, see the clot, find the best landing zones for the stent graft to get a good seal.
Right.
And even with drug-eluting stents, IVUS during and after the procedure helps predict who might get restenosis, re-narrowing, later on. Recent studies keep confirming this: lower complications with IVUS guidance, more accurate measurements than angiography, better detection of little tears after plaque removal, better detection of calcium.
So the evidence is pretty strong for PAD.
Very strong. It's also linked to less need for repeat procedures on the same spot. The authors of the chapter basically say, yeah, you should probably use IVUS liberally in most peripheral interventions.
Okay. Strong case. Now, what about those really tough blockages where you have to find your way back into the main channel? IVUS guided true lumen reentry.
Yes. That's a real challenge sometimes. When you're trying to push through a complete blockage, a chronic total occlusion, or CTO.
CTO, right.
Sometimes the wire goes into the wrong layer of the artery wall, the subintimal space. Getting back into the true lumen from there can be tricky.
I bet.
That's where devices like the Pioneer Plus are useful. They combine IVUS imaging with a re-entry tool, like a small steerable needle.
So IVUS guides the needle.
Exactly. The IVUS shows you where the true lumen is relative to the catheter, and the tool helps you puncture back into it accurately. Studies show it cuts down procedure time, improves precision, boosts success rates for opening up these CTOs, especially in the iliac arteries. Follow-up studies look good too. It really targets that specific technical hurdle.
Neat solution. Okay, moving up the body. Carotid arteries supplying the brain. Any role for IVUS there?
It's used, though maybe not quite as routinely as in peripheral or coronary arteries, but it has its place. One study looked at patients having carotid endarterectomy, the open surgery to remove plaque.
Yeah.
IVUS helped pinpoint the far end of the blockage more accurately than the preoperative angiogram sometimes did. That could help ensure a more complete cleanup.
Even in open surgery. Interesting.
Yeah. And for carotid stenting, IVUS can give extra detail about the plaque, help choose the best stent type and size, so it provides complementary information.
Okay. Let's switch to aneurysm repair. Endovascular repair, EVR for abdominal aortic aneurysms, AAAs.
Right, EAR. Planning is everything here, and that usually means high-quality CTA scans to map out the aorta, especially the landing zones above and below the aneurysm where the graft needs to seal.
CTA is the main tool.
Primarily. But preoperative IVUS can add value, especially in tricky cases. It gives accurate length and diameter measurements for those landing zones, helps pick the right endograft size. This can be really helpful if the aorta is very twisty, tortuous. Combining IVUS and CTA data can give a better plan for challenging anatomy.
So extra precision in planning. What about during the EVAR procedure?
Oh, intraoperatively, IVUS is incredibly useful for AAAs. Before deploying the graft, you can assess the access vessels, the iliacs, or femorals. If the CTA suggested they might be too small or diseased for a fully percutaneous approach,
Wow.
IVUS can guide things like atherectomy or angioplasty to prep the access, or help decide if you need a surgical conduit. This helps avoid nasty access complications like dissections or ruptures.
Preventing access problems makes sense.
Then, during deployment, IVUS lets you see exactly where branch arteries, like the renals, are, so you can place the graft accurately relative to them. If you're using a bifurcated graft, one with two legs, IVUS helps confirm you've successfully gotten the wire into the opening for the second leg, the contralateral gate.
Okay. And after the graft is in, does IVUS still play a role?
Absolutely. Crucial role. After deployment, you use IVUS to check everything. How well is the graft sealed against the aortic wall at the coppin bottom? How well do overlapping components fit together?
Checking the seal.
Exactly. And looking for endoleaks, any blood leaking around or through the graft? IVUS lets you see these leaks, figure out what type they are. This immediate feedback allows you to make decisions right then. Do we need to balloon more, add an extension cuff, put in another piece? This can prevent needing another procedure later.
Like fixing problems on the spot.
Yeah.
Okay, let's move up to the chest. Thoracic aortic disease. How's IVUS used there for TAVR, thoracic endovascular aortic repair?
So TAVR is used for a whole range of things: thoracic aneurysms, dissections, penetrating ulcers, hematomas, coarctation, trauma. IVUS can visualize and characterize all of these.
Like in the abdomen.
Yes, but with some added benefits specific to the chest. Often, the standard CTA for thoracic problems doesn't fully image the abdominal and pelvic arteries needed for access. IVUS can give you that critical information about the iliac or femoral arteries.
Ah, assessing access again.
Yes, and it's even more important here because thoracic grafts often need bigger delivery systems, so the risk of access injury is higher. IVUS helps decide if you need to prep the access route first. It also gives detail on the arch vessels coming off the top of the aorta, which might influence where you land the graft proximally or if those vessels need stenting too.
Getting a more complete picture than just the chest CPA might offer. What about specifically for thoracic aneurysms?
Similar benefits as for AAAs, plus those thoracic-specific advantages. Assessing access, planning coverage, sizing the graft, locating branch vessels and landing zones. It's all key. One really important thing in the chest, though.
Yeah.
This is IVUS's ability to spot potential sources of emboli in the aortic arch loose calcified plaque, mobile atheroma. Seeing that might make you decide not to balloon aggressively in the arch to avoid knocking plaque loose and causing a stroke.
Wow, yeah. Identifying stroke risk right there. That's critical. What about trauma? Blunt traumatic aortic injury, BTAI.
CT is still the main diagnostic tool for BTAI, tears, transections. But sometimes the CTA findings are murky, equivocal.
Not clear-cut.
Exactly. And one study found that in those unclear cases, IVUS was actually more sensitive than angiography at picking up injuries. A few patients in that study had negative angiograms, but did have injuries seen only on IVUS.
So it can find things angiography misses sometimes.
In those specific situations, yes. Another key point for trauma. The patient's aortic diameter can actually change between the initial CTA and the repair procedure because of shock, resuscitation fluids.
The size isn't static.
Right. So doing an intraoperative IVUS measurement is really important for sizing the endograft correctly at the time of repair. Getting the size right prevents problems like the graft folding inwards or not sealing properly. And since BTAI patients are often younger, you need that repair to be durable long-term.
Makes sense. Real-time sizing for a dynamic situation.
Yeah.
What about coarctation, that congenital narrowing of the aorta?
IVUS is important there too, especially for endovascular repair. A study on balloon dilation for coarctation found IVUS gave more detail than angiography about the vessel wall, how it remodels, any tears caused by the balloon.
Better detail.
Yeah. And interestingly, IVUS can even be used for diagnosis in infants and children. A study showed you could use IVUS catheters via the esophagus combined with 3D reconstruction to accurately diagnose coarctation or other arch problems.
Through the esophagus? Wow. Okay, let's tackle aortic dissection. That sounds incredibly complex. How does IVUS help manage that?
Dissection is complex, definitely. And IVUS is maybe most valuable here because it clearly shows the true lumen and the false lumen, the two channels created by the tear in the aorta wall. You can see that clearly in figure 32.7.
Seeing the two lumens.
Yes, and characterizing the tear, the entry point, any other connections, fenestrations between the lumens. You can also see the dissection flap itself, how thick it is, how it moves. That's crucial for diagnosing dynamic obstruction, where the flap movement blocks flow to branch arteries. Videos 32.3 and 32.4 show that.
Dynamic obstruction, right.
And for complicated type B dissections, those not involving the ascending aorta but causing problems, IVUS is invaluable for figuring out which lumen is feeding the vital abdominal organs, like the gut and kidneys. You can see which lumen the arteries come off of, which guides whether you need to stent those arteries. Seeing the celiac artery origin with IVUS also helps place the main graft precisely.
Understanding the plumbing in that messed up anatomy.
Exactly. And because IVUS gives accurate measurements and pinpoints branches and fenestrations, it helps identify the best landing zones for the stent graft, figure out the right size and length. And, like in other cases, it's critical for wire navigation.
Why navigation?
Because just using angiography, it can be really hard to tell if your wire is in the true lumen or the false lumen. IVUS gives you certainty. It confirms true lumen access, especially up in the arch. And if you need to make a hole in the flap, deliberately percutaneous fenestration to relieve pressure, IVUS can guide that too.
Okay, and after the stent graft goes in for a dissection?
Then you use IVUS to check the result. For type B, you look at the proximal end, make sure the arch vessels are open, check for any retrograde dissection heading back towards the heart. You assess the visceral arteries. Are they getting good flow now? Did the true lumen expand? Is the false lumen starting to clot off, thrombose?
Comprehensive check.
Very. And it's even useful for long-term follow-up after surgery for type A dissections, the ones involving the ascending aorta.
Seems indispensable for dissection. What about those other conditions, penetrating aortic ulcers, PAUs, and intramural hematomas, IMHs?
Similar logic applies. For PAUs, IVUS precisely maps the ulcer's location and size, which is key for defining the landing zones for the endograft and sizing it correctly.
Sealing off the ulcer.
Right. And for IMH, where you have blood within the wall layers, IVUS is great because it clearly shows those layers, the intima, the adventitia. This allows accurate graft sizing to make sure the diseased area is completely covered, and you can confirm the stent is well opposed afterwards.
Okay. We've hit arteries and the aorta hard. What about veins? Does IVUS work in veins too?
Absolutely. Maybe less talked about, but IVUS is very well suited for veins. It can characterize lesions, show vessel shape, give details venography just can't.
Better than venography.
How? Well, venography shows flow, shows connected veins, but it's not dynamic, doesn't show the vein wall well, and isn't great for precise sizing. Studies comparing them for things like iliac vein stenosis find venography often misses the tightest spot or misidentifies landmarks. IVUS often finds narrowings venography missed entirely, leading to changes in treatment plans.
So a more accurate map in veins too.
Definitely. IVUS can spot all sorts of things inside veins, plaque-like stuff, webs, scar tissue buildup, neointimal hyperplasia, clots, even problems with valves. And it gives measurements venography can't, which is important because veins are often irregular shapes, not nice circles.
Right, they collapse easily.
Exactly. So getting accurate cross-sectional areas, diameters, seeing the degree of compression that helps guide treatment, size balloons or stents correctly, and IVUS measurements of narrowing actually predict clinical improvement better than venogram measurements do.
Better predictor. That's compelling. Specific venous issues.
Right.
Like DVT, deep vein thrombosis.
For DVT, IVUS can sometimes spot underlying lesions missed by venography. It's also more sensitive for finding residual clot after treatment, which might argue for using it more routinely with clot-busting drugs.
Okay.
But where IVUS is probably used most often in the VTE world is for placing IVC filters.
Filters in the vena cava. Why IVUS there?
Because precise sizing of the IVC is critical for filter placement, and IVUS gives you that. It also clearly shows branch veins like the renals, so you place filter correctly relative to them. Studies show using IVUS instead of contrast venography for filter placement is safe and effective. Plus, you often don't need contrast or fluoroscopy, and sometimes you can even do it at the patient's bedside without moving a critically ill patient to the cath lab or OR. Huge benefits for sick patients.
Big advantages for safety and logistics there. What about that condition, CCSVI? Chronic cerebrospinal venous insufficiency?
Right, CCSCI. IVUS helps there by assessing the size and looking for abnormalities inside the jugular and azygos veins, the ones draining the brain and spine. Things like valve problems, webs, narrowings. Venography doesn't always show these clearly.
So IVUS sees internal details better.
Yes. Abnormal valves often show up well on IVUS. One study actually found catheter venography was less effective than IVUS or even color Doppler ultrasound at finding malformations inside the jugular veins. And that study also found Doppler tended to underestimate the vein area compared to IVUS.
Interesting comparison.
And sizing is tricky in the jugular vein because it's not round. IVUS helps get balloon sizing right, which has always been tough for treating narrowings there. Helps avoid complications from using the wrong size balloon.
More accurate assessment again. Okay, lastly, venous compression syndromes.
Yeah.
Maytherner.
Yes, IVUS really helps with those. Figure 32.9 shows some examples. For Maytherner, where the left iliac vein gets squished by the right, iliac artery studies show IVUS finds the blockage more reliably than venography, often confirms the diagnosis and guides stenting.
Finds it more often. Okay.
Same story for general ilifemoral vein obstruction causing leg swelling. IVUS is more sensitive and accurate than venography. For nutcracker syndrome, left renal vein compressed between arteries, IVUS visualizes the compression beautifully, aids diagnosis, and helps with intraoperative sizing. Figure 32.10 and a video show this.
Even for thoracic outlet syndrome.
Yes, TOS2. An older study showed IVUS helped limit the surgical dissection needed. More recently, studies show IVUS gives a more detailed look at the subclavian vein compared to venography, better identifies narrowings. Videos 32.6 and 32.7 illustrate TOS and even pectoralis minor syndrome, another compression issue. Basically, for any condition where a vein is being squeezed, IVUS gives a much clearer picture.
It really is incredibly versatile across arteries and veins. But like anything, it must have limits, risks.
Of course. Nothing's perfect. When you stack IVUS up against other imaging tools, well, it has clear wins, like measurement accuracy and seeing lesions in the aorta and peripheral arteries.
But other tools might be better for other things.
Right. 4V MRI has great plaque characterization, but it's expensive, slow, prone to artifacts. OCT has amazing resolution in small arteries, but doesn't penetrate deep, small field of view, needs contrast, need to clear blood out.
Trade-offs again.
Exactly. Angiography still shows flow pathways well. FFR measures flow restriction hemodynamically, but not morphology.
Yeah.
IVUS is generally seen as better than angio alone for patey details like diameter, stenosis, plaque type, calcium. So you pick the best tool or combination of tools for the question you're asking.
Makes sense. What about risks of IVUS itself?
Well, it is invasive. You're putting a catheter in a vessel, so there's a very small risk, less than 0.5% major complications reported of bleeding, clotting at the entry site, or damaging the vessel. Usually, if problems happen, it's during the intervention part, not just the IVUS imaging itself.
Minimal risk, but not zero.
Correct. And we already talked about the cost, the system, the single-use catheters. That's a definite factor.
And image quality. You mentioned comparisons.
Yeah, image quality can be a limitation. Compared to OCT or even standard external ultrasound, IVUS images can sometimes have lower signal-to-noise ratios, more artifacts. Frame rates are lower than standard ultrasound. This is something vascular docs mention.
User-dependent, too, you said.
Highly user-dependent. Choosing the right catheter, the right frequency, tweaking the settings to minimize noise and artifacts, getting accurate measurements, that takes skill. And interpreting the images requires experience recognizing artifacts, understanding how catheter position or vessel bends affect the view.
So training and support are key.
Absolutely. Trained techs, clear protocols, good education for the doctors using it. That's all essential to get the most out of IVUS. It's powerful, but needs expertise.
Okay. So looking ahead, what's next for IVUS? Future advances.
The future looks pretty exciting, actually. There's work on forward-looking systems, maybe using these things called CMUT arrays, integrating ultrasound and electronics on one chip.
Forward-looking, not just sideways.
Potentially, yeah. Could even lead to IVUS capability right on the guide wire itself, which would simplify things a lot.
IVUS on a wire. Wow.
That's the hope. And lots of effort is going into better plaque characterization. There's a big trial, Prospect 2, looking at a catheter that combines IVUS with NIRS near-infrared spectroscopy.
NIRS, what does that add?
NIRS seems better than IVUS at identifying those soft, lipid-rich, vulnerable plaques in coronary arteries. So combining them could give a much more complete picture of lesion risk.
Combining technologies.
Exactly. That seems to be the trend. Combining IVUS with other diagnostics like FFR or NIRS, or even integrating it directly with treatment tools like angioplasty balloons or ablation devices on a single catheter. More integrated, higher resolution, easier to use. That's where it seems to be heading.
Very cool. Well, this has been a really comprehensive look at intravascular ultrasound. Let's try and boil it down to some key takeaways.
Okay. I'd say, in summary, IVUS gives us this unique, incredibly valuable view from inside blood vessels.
That inside view, yeah.
It provides critical guidance for a huge range of treatments, lets you check your work immediately, cuts down on contrast and radiation, and it works across so many different arterial and venous problems. It's remarkably versatile.
Agreed. And thinking about the future, it's just clear that this kind of intravascular imaging, IVUS and whatever comes next, is really changing the game for understanding and treating vascular disease. It makes you wonder, doesn't it? What other innovations are coming down the pike that will push things even further, make care even more personalized?
Definitely a space to watch.
For sure. So, if any specific uses we talked about caught your interest, maybe dive deeper into those. Or just think about how these inside view technologies might be changing other areas of medicine too. Thanks for joining us on this deep dive.